This episode of The Curbsiders is available for CME and mock credit through our partnership with the American College of Physicians. ACP members can go to acponline.org/curbsiders and claim their free CME and mock credit. Thank you and enjoy the show.
You know what we missed? We missed the perfect opportunity to ask Dr. Tony Breu what his favorite brew was. Dr. Breu's Brew.
You can tweet it at him, Stuart.
I wouldn't.
Will do.
I wouldn't either, Paul.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect the official policy or position of any entity, aside from possibly Cash-Like Moral Hospital and affiliate outreach programs. If indeed there are any, in fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to The Curbsiders.
Well, hi, Matt.
Hey, Stuart. How's it going?
It's okay.
I thought I banned you from being a downer in the intro.
That's right.
All right. All right, Stuart. I'm glad you're. I thought we just had a really fun time recording with Paul and Chris and our wonderful guest Tony. Paul, are you here?
I'm here.
Okay, Chris.
I'm still here.
Okay. All right. Paul, I'm sorry. I guess Chris introduces this episode instead of you. And before we get to Chris for that, I just wanted to give the audience a heads up of what this episode's going to be. So we went through a bunch of Hotcakes articles. Topics this month are aspirin. We talk about fish oil. We talk about hypertension a bunch. And we talk about the effects of exercise on mortality. It's a great discussion. And before we get to it, Chris is going to tell you a little bit about this show format and our guest.
Today is another edition of Hotcakes, where we discuss the most interesting articles and news that we've been reading. We have a very special guest with us today this episode. A few months back, when we first started Hotcakes, we had a listener tweet at us that he wanted more historical articles. Well, we have this notorious listener with us today to help talk about some of his favorite quote-unquote cold cakes. This internist may be well known to most of you on Med Twitter because of his tutorials. As many of you guessed, our guest is the prolific Dr. Tony Breu. Dr. Breu is the assistant professor of medicine at Harvard Medical School and a hospitalist and the director of internal medicine resident education at the VA Boston Healthcare System. His research interests include no-value care, also known as things we do for no reason. He is also core faculty at the Harvard Center for Bioethics, where he is a course director and co-course director of a number of classes. Great to have you on, Tony.
Tony, thank you so much for joining us on the show. And before we get into all these great articles we're going to talk about tonight, I just wanted you to give the audience a one-liner to describe yourself and add in something that you do outside of the world of medicine.
Fantastic. Well, thanks for having me on. I'm super excited to be here. I'm a 40-year-old husband to an amazing woman and father to 2 young children. Clinically, I work as a hospitalist in the VA system, caring for veterans in the New England area. And I love researching things we do for no reason, as some people who followed some of my work in the Journal of Hospital Medicine may have noted. And outside the hospital, I'll be honest, I'm a depressed New York Mets fan. Baseball season's over, and I can't really say that I'm excited for next season because I don't know that it's going to be much better.
Okay. So you just take my tact. I don't watch any sports, and then I feel great.
Well, I'm a New York transplant to the Boston area, which cannot be a good thing.
Oh, that's rough.
No.
Let me ask you what your guiltiest pop culture pleasure is, and I'll self-disclose just so you don't have to feel bad. Mine, for instance, would be the movie Basketball, which I would not recommend because but I love it more than almost anything. So what piece of pop culture do you enjoy but are also ashamed of liking?
Actually, I'll mention 2 things. One is pretty much any Bravo TV show. My wife constantly has Bravo on in the background when we're trying to get our children to bed. So things like Below Deck. I would be lying if I said I didn't pretend I wasn't watching it, even though I'm definitely watching it. And then this one I'm not as guilty to say, but it may be a little bit surprising. Moana, the movie with Lin-Manuel Miranda wrote the soundtrack to it. Yeah, every Friday evening my wife works late, and so when I come home with my daughter, I make the offer that we can watch Moana. And I'm, I would say 51% doing it to make an offer to my daughter because she loves the movie, but 49% because I love the movie myself. It's just really fantastic.
It's just a delight. I
really
couldn't
is.
agree more, actually.
I've never seen it.
Oh, wow.
It's so good.
You should, and afterwards you'll say you're welcome.
Yeah. Nicely done.
Yeah, Stuart, and your kids. I think your kids would even like it. Regardless, I know your daughters are teenagers, but they would like it. Well, two of your daughters are teenagers.
I'm 40 years old and I love it.
Yeah.
Yeah, Stuart, it's good. It's really good.
I think the only one who would sit down and watch it would be my son, who's 10. And then he'd look at me and say, "You're crazy, Dad."
I don't think so. I think it's
got
good.
The Rock.
Yeah.
It's good. It's good.
All right.
Fair enough.
So now that we've debated Moana, Chris, maybe we should move into the show.
So, where did the idea of the tweetorial come from? And I don't know. What do you think about them?
Well, so
Probably like some.
Yeah, no.
So I definitely did not invent the tutorials. You guys likely know. Daryl Francis, cardiologist in the UK, and Vinay Prasad, oncologist out in Oregon, both were doing this far before I was. Basically, I wrote one about the anemic response to acute hemorrhage and was floored by the positive response. And it was a little bit of an adrenaline rush, I have to admit. And so I realized, well, let me try this again and see if people come back for more. And the reality is that doctors are really interested in pathophysiology. And if you can make the question one that is relevant to their day-to-day practice, or one that they maybe have asked but just didn't know an answer to, you're going to get buy-in. And the beautiful thing about Twitter is even though it's short, you can string together 10, 15, really no more than that tweets and get people's attention. So I'll tell you something, I've learned so much, and it's made teaching on the inpatient ward significantly easier because now I feel like I have this cadre of things I can teach about that 6 months ago I had no clue the answers to.
So there's actually an entry on the Urban Dictionary for tweetorial now, which I think is kind of funny.
Wow.
Yeah.
What does it say?
It says, a tutorial made by stringing together a series of tweets. A tweetorial is therefore a long or extended tweet and is used only on Twitter. As with tweets, one can add hashtags, links, polls, and short videos for tweetorials.
It's actually got a definition now online. It's so interesting.
Yes. Yeah, I know. I didn't expect it when I Googled it when you were talking about it.
Okay.
All right. So I guess maybe we should just get into our articles now.
Yeah.
All right.
I think so.
Our first article goes to Tony since he is our guest, and he really wanted to bring us some good old-fashioned historical journals, so we're going to call them cold cakes. And he definitely picked a pretty good one. I think aspirin has been in the mind of a lot of internists lately, a lot of primary care providers and cardiologists, because we've just had a whole bunch of aspirin articles, and those were mostly pointed towards primary prevention, but we have some. Tony picked a really cool article that has aspirin in it about treatment. So it was a little different, but I think it goes with the theme of some of the things that we're thinking about recently. Tony, do you want to tell us about this?
Yeah, so this is the ISIS-2 trial. As Chris, you mentioned, is a little bit of a cold cake, published in 1988. But I chose this article for a couple of reasons. One, because I feel like aspirin is one of those things in medicine that nobody questions, right? Acute MI, you get aspirin. But I found that when you push a little bit harder and ask people, all right, well, what's the actual benefit? There's a little bit of sputtering. People don't necessarily know how good it is. They assume it's good, but they don't necessarily know how good it is. And this became quite palpable a couple years ago when we had a guy at VA who was having an acute MI and was also having intracranial hemorrhage from mets in the brain. And we had this debate, oh my gosh, should we give him aspirin? Should we not give him aspirin? And until we look back at this study and realize that, okay, aspirin's good, but it's not like it reduces the risk of death by 95%. Until we did that, we assumed it would be ridiculous to withhold this absolutely, clearly life-saving therapy. And so that, in addition to a few other things, was why I kind of wanted to discuss this paper, because I think some of your audience well, I'm sure all of your audience knows that aspirin is therapy for acute MI, but they may not have a sense for actually how good it is. And so I don't know if you guys had a chance to look over the paper and had any thoughts on the actual strength of benefit and whether or not it surprised you, either was better than you thought, was worse than you thought, or kind of met the expectation that you had.
All right, so Tony, in the ISIS-2 trial, what was the population they looked at, and what were the different interventions that they used?
Yeah, so they included over 17,000 patients, and it wasn't just aspirin. It was this, I wouldn't say complex, but a little bit more complex than the usual single-arm placebo-controlled trial. It actually had an aspirin arm and had a streptokinase arm, so they actually were evaluating thrombolytics at the same time that they were evaluating aspirin. And so all the patients that were enrolled, these 17,000 some odd patients, all had suspicion for acute MI. And about 50% of them had STEMIs on their ECG. And the rest of them had, either SC depressions or other changes that were consistent with acute MI. And they were randomized to either aspirin, streptokinase, both, or neither. And the primary outcome of this trial was vascular death at 5 weeks. So pretty short term in terms of when they were looking to see if aspirin had any benefit.
What struck me about this is that it was so semi-recent. I mean, in my lifetime, and you could include a no treatment in this, like a placebo, because nowadays, nowadays that would not fly. So that was one of the main big things that jumped out to me at this, and that they were still trying to figure out if aspirin alone or aspirin in combination with streptokinase was better than nothing. So it's just like it's relatively new. This whole field of like treating acute myocardial infarctions. I think stents were in the sort of like the late 70s, early 80s. And since then we've been iterating all this, trying to figure out what's the optimal treatment and everything. And I think this was one of just the main like landmark trials.
This is to my mind a top 5 in internal medicine, and exactly as you said, Matt. This was in some ways a little bit late, at least in the aspirin game. I mean, there were studies on secondary prevention and in unstable angina that had preceded this, but the idea of giving aspirin for acute MI wasn't as clearly defined as it became after the study was published. And, 30 years ago, that's a long time ago. But if I had to guess before I knew it was 1988, I would have guessed that aspirin therapy for acute MI was even older still, like, maybe 60s or 70s, not 1988.
Yeah, so recently we had discussed both the ARRIVE and ASCEND trials for the utility of aspirin for primary prevention. And it doesn't really show, at least in the ARRIVE trial, the ASCEND, plus or minus, depending on if we look at the risk-benefit profile, it doesn't really look like there's a significant benefit for primary prevention. I want to know if maybe these newer trials might change the way that you interpret the ISIS-2 trial, knowing that the prevalence of statin therapy is likely blunting the effect of aspirin therapy.
I think it's a great point. At the time they did ISIS-2, the therapies that we had available for an acute MI, and we'll use STEMI as maybe the best example, weren't as we didn't have as many of them, right? So statins, as you mentioned, Stuart, was one. And at this time we had thrombolytics. I mean, thrombolytics was one of the arms, but we didn't have primary PCI and stenting. And so my guess is that, as you mentioned, Stuart, the effect of aspirin here, with a relative risk reduction for 5-week mortality of 20%, that probably would be blunted if we repeated the trial in 2018. I don't think aspirin would be shown to be nearly as effective.
So is no one going to bring up the elephant in the room, that one of the secondary outcomes they looked at in the trial was a subgroup analysis of zodiac sign?
Yeah, so this is my other this is my favorite paper of all time, and that's one of the reasons. I don't know if you guys caught this, but it is like, so the history behind this is that the author submitted it to Lancet, and Lancet said, okay, great, this is wonderful, fantastic, 17,000 patients. We want a subgroup analysis. And the Lancet authors were like, fine, but you got to let us put whatever subgroups we want. And they chose to separate it by the 12 astrological signs to demonstrate the fact that if you cut a set of data up enough, you're going to find a false negative, right? So people born under the signs of Gemini or Libra, according to this study, have no benefit for aspirin.
Uh-oh.
It sucks for them, but that's what the subgroup analysis showed. And that's obviously clearly not the case. Aspirin is beneficial in those patients, but it was meant to show that if you chop up the data in enough ways, you'll find these false negatives.
Or they may have uncovered something remarkable.
It's quite. There may be something very, very odd about being born on June 10th, and aspirin just doesn't work if you're born on June 10th.
We need to follow that one up.
I think that needs a tweetorial. You can speculate. You can speculate how the physiology of how that might work.
All right, Tony, how many cold cakes do you give this one?
Out of how many cold cakes can someone actually get?
Oh, Tony, don't indulge
Tony,
us.
As many as you want.
How many cold cakes can
Chris, I can briefly go over the scale. So we'll just have it parallel our hotcake scale. So six hotcakes is a full stack. So 3 hotcakes is a half stack, and the same for cold cakes.
Okay.
I honestly don't think I knew that.
So I would give this. I'd give, if you're not a Gemini or a Libra, I'd give this a full 6 hotcakes. If you're a Gemini or a Libra, unfortunately, it's got to be a 0.
Yeah.
Awesome.
Makes sense.
All right, let's move on to the next one. So Paul's pick, as you would guess, his pick is from the recent article in the Journal of Clinical Psychiatry on the fact that cessation,
marijuana.
Yeah, the fact that cessation in cannabis is tied to memory improvement. I'm sorry, I'm kidding. Now, Paul decided to do a cardiovascular study as well. Paul, do you want to tell us about it?
Sure, I'd be happy to. And I should mention when the cannabis article came out, I felt almost resigned to have to do it. Like, I'm tired of talking about it and thinking about it, but it's become my shtick now. But there's another article that came out, and I chose it because I need your guys' help with it. I'm just not quite sure what to make of it. It's from, and apologies to Dr. Mansager for mispronunciation et al. In the JAMA Network Open. And this made the news rounds. It's the Association of Cardiorespiratory Fitness with Long-Term Mortality Among Adults Undergoing Exercise Treadmill Testing. And so basically the background for this is, and what I think is interesting about this article is how they frame their conversation and the discussion and the point that they're trying to make. But the background is there's some recent studies that I think involved a fair amount of Schadenfreude, in that they suggested that people who exercised a whole lot actually maybe had cardiovascular problems. So there was concern for associations between really high levels of exercise and atrial fibrillation and myocardial fibrosis and LV and RV remodeling. And I feel like it was a way for those of us who don't exercise much to feel kind of smug about the people who actually are taking the time to take care of themselves. And so this article ostensibly is to address that. So they use this as background. And what they did was they looked at, it's a retrospective chart review that actually looked at 122,000 patients that underwent exercise treadmill testing for whatever reason. So that's part of the selection criteria. So that maybe for symptoms, maybe for evaluation of CAD, or maybe for other, they didn't really worry too much about that kind of stuff. And they basically assessed how fit the patients were that did this. And so they used the exercise treadmill test to actually assess METs, and then based on the METs, actually stratified patients even further in terms of how fit they were. And so there was elite performance and high and above average and below average and low performing. And then this was further stratified among age groups as well. And so basically, reassuringly, what the study found after a lot of statistical massage,
After exercise.
Yes, a lot of exercise, a lot of stretching, is that patients who are extremely fit, who are in this elite performance group, had these very high level of METs, died less. And the patients who performed poorly or well below average in the low category had a higher mortality. And so their takeaway from this was interesting to me, in that it was basically a prescription to exercise really, really hard, because that is as preventive as anything else that we have. And then actually low exercise, and this was kind of buried, I thought, was actually considered to be an even sort of worse prognostic indicator than things like smoking or CAD or diabetes or high blood pressure. So, but it's what I mean by the framing of it. I thought was very interesting that they're like, good news, exercise is good for you again, even though I don't know that any of us really thought that wasn't the case. And so, but to me, it's more interesting in terms of how it looked at patients' functional status at a moment in time, and how that is actually a fairly decent predictor of mortality. So I took away a little bit of a different take-home point than what the authors sort of framed the conversation as. So this is a prescription for exercise, whereas for me, exercise treadmill testing does not, the way the study was designed, the limitations are you're looking at one test in time and not someone's whole fitness background, how much they've exercised over their lifetime. And it just doesn't take a lot into account, including socioeconomic stuff and the reasons for referral. And there's just a lot of intangibles and unknowns that I don't know that I could come to quite the conclusion that they came to. But I think as a predictor of mortality, and in terms of functional status, I think the exercise treadmill test actually was pretty good. So that was sort of more the takeaway that I got from this. I'm not sure if you guys had a chance to look at it or what your thoughts were.
Tony, you can go first. What do you think?
Well, I'll tell you, it's a little bit reassuring because I definitely consider myself an elite athlete in all capacities, and so
sure.
I had always worried that I was on the wrong end of that U-shaped curve.
Yes.
But actually, in honesty, this is somewhat reassuring because I do a fair amount of preoperative medicine, and we do exercise treadmill tests more often than we probably should. And I don't think I have to worry nearly as much about am I giving someone false reassurance, sending them to the operating room after they've done well on the stress test. Now, I know this is not exactly what the study was aiming to look at, but it's reassuring that if you can exercise, you're probably in pretty good health. That's intuitive, but it's nice to see after looking at 120,000 patients that it probably holds true.
Right.
Paul, I just wanted to highlight what you mentioned it when you were giving your overview, but the below average fitness on this treadmill test versus someone who was above average. So not high and not elite. So someone that was just above average. That was the difference compared to someone who was below average of like having that below average person might as well have diabetes or might as well be smoking. Like there was as much of a difference between those two people as if the other person was smoking. So let's just to highlight, because I don't know if I said it that well. Let's say if you were a below average person on the exercise test.
I think we can all agree. I am solidly below average. So I'm so far your thesis holds up.
I wasn't referring to Paul specifically, but that helps the example. Paul, I just wanted to highlight that the difference between someone who is below average on an exercise test and an above average person was as if the below average person was smoking or had diabetes. That's some of the examples that they gave in there. I think that's pretty, it's a pretty good motivation to start exercising.
Right. Or start smoking.
Sarah, our producer, wants to know what about Gemini?
Were the zodiac signs tested? I didn't notice it when I was looking through the article, Paul.
That was not a subgroup analysis I saw. I can only assume Geminis did poorly.
Yeah, I think this was.
Well, they must have done poorly because they weren't even if they were taking aspirin, they would have died from their
No
MI.
difference.
I think, and this has gone back. Like I've kind of heard rumblings of this, that there was like an elite marathon runner or somebody who like blew out his right ventricle or something like that and had to stop and had myocardial fibrosis.
Had to stop? Oh goodness.
Had to stop running marathons. Yeah, so there was like this kind of buzz among like these like ultra athletes that maybe it's not great for your heart to be at the elite level.
Yeah, he may have only died if he wasn't an elite athlete. And my goodness.
So
I wonder how much of that has to do with surveillance. Like I've not been able to dig it up in the background literature, but you have these ultra elite athletes. Like I imagine they're probably seeing physicians and trainers far more often than sort of the average person who goes for a run every so often.
Well, you should look at the FAA data for pilots, and you see the same thing. So because it's more sensitive, so they're going to pick up a lot more cases early on.
Yeah.
Yeah, I mean, one of the things I look at with this study is I don't do outpatient medicine. I know a number of you guys do, but I suspect you have patients who get frustrated that they're not losing weight when they exercise. And you can say to them, look, weight loss is nice, but your fitness and your overall health is clearly benefiting from the exercise you're doing.
Absolutely.
That's a great point.
Absolutely.
Yes.
Yeah. Maximum benefit is typically seen around 5 to 10% of total body weight. So anything more than that is just, extra. No pun intended.
All right. We need to be wrapping up on this one. So, Paul, how many hotcakes? Because I know you love giving hotcakes.
I mean, I don't know, man. 3. It's 3 hotcakes. What are you doing? What is this?
It's only going to get weirder from here because our next article, Matt chose, and our very own Sarah Roberts also trademarked this. We're calling it a future cake because it has not been published yet. And it's called the Reduce It trial, apparently, and not to be confused with the Improve It trial, which is the ezetimibe study, or the Reduce trial, which is the COPD study. So, Matt, do you want to tell us a little bit about this study? Hi, it's Chris here. I actually want to break into the middle of the conversation, and I want to say that this episode was recorded before the Reduce It trial was released, and now it has been. So just keep that in mind and enjoy the rest of the discussion.
Sure. Thank you, Chris. So this was a little bit of a misunderstanding on my part because I chose the article based on the headline, and then I was too far into it by the time I realized that it wasn't fully published yet. But I didn't want to have to notify everybody like 2 days before our recording that they're going to have to do a new article. So anyway, this Reduce It study is much anticipated. It kind of has to do, it's not quite fish oil, but it's in that vein. So Vascepa, VASCEPA it's a type of like EPA that is made by the Aspirin Corporation. And there's a little bit of an interesting history here. And the reason we chose this is because they announced that they have a signal in their data that for patients who are already treated with a statin, that have had cardiovascular disease, that if they're already treated on a statin and their LDL is low, but their triglycerides remain between 150 and 499, that they have found a 25% reduction in major adverse cardiac events in that population with the use
only for Gemini or Libra. With
the use of this medicine. I'll use the generic icosapent ethyl, which is a type of EPA. It's like it's not EPA and DHA in the pill. It's just the EPA portion of it. And so basically this is a medicine that was initially only FDA approved for triglycerides over 500. And about 2 years ago, the company actually sued the FDA so that they could market it to people who had a triglyceride level between 150 and 499. So they sued the FDA, and the FDA, I guess, backed down and said, okay, fine, even though it's not officially approved for that, they can market it for this off-label use. And then they had this big trial going on, which is the Reduce It trial. The lead investigator is a big-time investigator. He's at Harvard, Brigham and Women's, and he has over 750 publications. And he's the lead of this trial, where they had 8,179 patients. And basically, these were people that were at increased cardiovascular risk. So they either had known cardiovascular disease where they were looking at it for secondary prevention, or they were at high risk where they had diabetes plus another cardiac risk factor. And then it was a blinded, randomized controlled trial, placebo-controlled trial, where they were taking 4 grams of this icosapent ethyl I'm just going to call it EPA because it's easier. They were taking 4 grams of this EPA per day, and they found a 25% relative risk reduction. Now, we don't have the absolute numbers. We don't have the absolute data. It's just like a nice headline that it says, like, for patients already treated with statin, now we add in this EPA, and these patients are going to have a decrease in major adverse cardiac events. And Stuart's putting up for me here, which this is something I had looked up. So Stuart, 120 tabs. It looks like it's more expensive in your area code. In my area code, 120 tabs, because you have to take 4 capsules of this a day in order to get the 4 grams they were taking in the study. And it was $240. And Stuart's quoting me $300 to $350 in his area code for this medicine. So I just thought, the whole, and then the conclusion of this, I kind of looked back in the literature a bit. In the basic science literature, there's a lot of stuff that says like EPA helps favorably change your lipid profile and decrease inflammation. And there's even some imaging studies saying that it like stabilizes plaques. But then there's a Cochrane review that just came out this year looking at EPA and DHA that says basically like all the studies that have shown benefit have moderate to high risk of bias, and there's no evidence that we should be using this. Pretty against it. And now this study is going to come out at AHA. They're going to present it at November 10th at the AHA meeting. So I'm just interested to see what comes out of this. And I just thought it was interesting that this started with this company suing the FDA so that they could, market it for this indication even before the results of this study were published. So that's a
Matt, do you
think
this is so is it fish oil or snake oil?
I'm confused now, Chris. That's part of the thing. Like I thought I was, I had seen the Cochrane review and I was like, okay, EPA, DHA thing. I think we can finally put fish oil to bed. And now this is like a big trial. Seems like it was well done. At least it was done by like a very accomplished researcher, but it is industry funded. So we'll have to see the full data, but I'm very skeptical of fish oil. And I will refer back to our nutrition episode where we talked about the PrediMed study. We talked about the Lion Heart study, and both of those had a great reduction in all-cause mortality by just following a Mediterranean diet. So that would be, and cardiovascular risk reduction. So I would recommend a Mediterranean diet. It's probably, a bit cheaper than buying these pills and maybe more enjoyable too.
Yeah, tastes wonderful.
Yeah, Deepak Bhatt, who's the lead researcher, he and I overlapped at VA when I was there as a chief resident, and then when I came back for my current job. And he's one of the only people I know who had 2 first author publications on the same day in the New England Journal of Medicine. I mean, he is an amazing researcher.
Yeah.
That doesn't mean that this product is worthwhile, but as someone who's able to put together a clinical trial that probably is valid, he's the kind of guy who I suspect could do it.
Right. Yeah.
Well,
and that's part of
be on the lookout.
Exactly. That's part of what's adding to my confusion here. But that's one of I think that's one of the humbling things. And I don't know, Tony, what you feel about this, but when you actually go back and look at the level of evidence and all these things that we do all the time, there's just so much uncertainty around, and things are good one minute, then the next minute you find out they don't work as well as you thought, or vice versa.
Yeah, and it's an interesting comparison, right? You look at the primary endpoint for a trial like this, and it's a composite of cardiovascular death, non-fatal MI, non-fatal stroke, coronary revascularization, unstable angina, and then you compare it to ISIS-2, the first study we talked about. It was vascular death. I mean, it's
right. And
it's really dramatic, the changes that we've had to make in the composite endpoints we have to use to find a difference in therapies.
Yeah, right.
And that's kind of like one of the issues that I really kind of have with these trials is just these massive composite endpoints that we include. And to me, that's just, I don't know. I'd like to see the data.
Yeah, we don't, because we don't know which composite endpoints, if any, was driving this 25%, reduction when you look as a composite. So.
Yeah. And if it's coronary revascularization, I mean, all that we're seeing in the use of that therapy for stable angina, it really makes you question ever including that outside of an acute coronary syndrome.
I love that point. That's a great point.
We can move on to the last 2 articles, and they are actually very closely linked. You see, my pick this episode is a new article that just came out last week on the management of hypertensive urgency, and it was actually written by Tony here, and in his Things We Do for No Reason series. And so his actually cold cake pick is actually complementary to it because it's actually featured in the discussion for the article. So, Tony, do you want to talk about your pick, and then we can talk about your article?
Yeah, so if going back 30 years wasn't cold enough, I thought we'd go back 50 years for the second paper. So the other paper I thought we'd talk about was the 1967 VA cooperative study. So this was, I don't know if it was the first VA cooperative trial, but I know it was one of the earliest ones. And this study basically laid the groundwork for the treatment of essential hypertension. So preceding this, the treatment of malignant hypertension, where patients had extremely high blood pressures and had papilledema or acute kidney injury, that was clear, but there was a lot of debate still about whether or not treating essential hypertension was necessary. And as you guys probably have heard, the term essential was used because there was a feeling that in order to perfuse the organs, you needed this high blood pressure. Like it was essential to the perfusion of organs. So this trial, Brigham randomized patients to either a combination of hydrochlorothiazide plus hydralazine plus reserpine, so 3 medications, or placebo. And it included patients who had diastolic blood pressures in the order of 115 to 120, in that range. Oof. And it followed them out for an average about 1.5 to 2 years. And the difference was striking. So, at that point, 1967, there wasn't really a primary endpoint. They basically just observed patients and accumulated events. And, if you look at things like death, stroke, MI, heart failure, renal failure, hospitalization, you just basically add up all those things. The difference between the two groups was 39% versus 3%. So that's a number needed to treat of about 3. You really don't get much better in internal medicine than a number needed to treat of 3. And as I mentioned, this is really one of the foundational papers in internal medicine. This laid the groundwork for why we treat hypertension, essential hypertension.
So actually, one thing I'd like to bring up is actually some comments when we were all working on the notes for this. Is Sarah, our producer, also brought up some interesting points as we look at some of these older historical journals. There's some things that may look almost unethical as they do some of these studies. Do you want to comment a little bit on that?
Yeah, I think Sarah raised a number of interesting issues, and I think she's right that some of the ways that this trial was conducted probably wouldn't fly in 2018. In particular, this trial probably would have been halted a bit earlier than the 2 years that it was halted in this case. I mean, 40% versus 3% in terms of the difference in pretty hard outcomes. My guess is there would have been some data monitoring in an earlier fashion, and the trial would have been halted for clear benefit. The trial was ended early, and the patients who were on placebo did get therapy. But I suspect the monitoring and the trial went on longer than it would in 2018.
Tony's article is very interesting, and he actually mentions it a little bit in his new article that came out last week on his Things We Do for No Reason. He co-wrote this with, is it Neil Axon? Is that right, Tony?
Yep, Neil Axon.
And basically, it's sort of a discussion, and definitely has been a discussion that has come up multiple times, especially among our emergency medicine colleagues. I mean, I've heard it multiple times in other podcasts as well as all over Twitter about the discussion of hypertensive urgency and whether it's really a thing. And I think it's a very short couple of pages, but really talks about a lot of the reasons why we look at hypertensive urgency, why we feel like we have to treat it because of the sort of bring it together with hypertensive emergency and whether it's harmful or not when we're actually treating it. And I think it was a very well-written article that really puts together all the information that we actually know on the subject. And it really shows that we don't actually know if it is beneficial to treat these patients with just elevated blood pressure and no other symptoms. Is that pretty much a pretty good summary of? Am I having a good takeaway from that, Tony?
Yeah. What I'm hearing really more than anything is that it deserves 10 hotcakes.
Yeah. Yeah, I heard the same thing.
Yeah, I would say that, so I think that this, we try to highlight sort of two separate things. There's the question of whether or not there's benefit to acutely lowering patients' blood pressure when they have hypertensive urgency. And then there's the question of harm. And there's no great randomized control data on this, but there likely is no benefit. The question of harm is harder. I think if you do this enough times, you'll eventually cause severe harm in some patient. But I think we've all likely done this dozens of times, and maybe patients feel a little bit lightheaded, maybe patients fall. Knock on wood, I've never caused a stroke or an acute MI. I hope none of you guys have either. So I don't think the harm is definite, and meaning I don't think that we're causing tremendous adverse events all around. But it's such a prevalent action that we do that in aggregate, I think there's harm that's being done. I'm not sure if that makes sense.
Oh, no, I completely agree. I remember back in residency when we would admit a patient, there's a whole order set and a whole section is just like PRNs for hypertension. And we would, as a resident, I would just automatically check those. And didn't even have a second thought in doing that. I don't know if everyone else had similar experiences during their inpatient experiences.
I think I fortunately or unfortunately gave IV hydralazine to a patient on my night float rotation, which was my first block of intern year, and bottomed out someone's blood pressure. And my senior resident, who was eventually a chief resident, who I'm still friends with, was like, "Don't do that." What, basically, did not believe in this practice, and told me why it was not a good idea. And so I learned. Fortunately, the patient was just lightheaded. We laid him down, gave some fluids. He felt fine. But this was, nothing bad came out of it other than the momentary discomfort and me feeling tremendous guilt. But I find the one thing that's hard is it's very hard to. A lot of times you'll come in working in the hospital, and this will have been done at Cashlack overnight. Someone's pushing IV hydralazine on your patient, or somebody was messing around with the blood pressure medications. And I think, Tony, my favorite point in the article, I thought it was great. It was just sort of kind of coming to the conclusion that maybe the right thing to do is to look at what they're taking and kind of, decide, does this person have chronically uncontrolled high blood pressure? Do we believe these numbers we're seeing? Is there no underlying cause for it? And can we just go up on some of their long acting agents? Because we know that in the next few hours, we're probably not going to cause them any benefit by bringing down their blood pressure for a hypertensive urgency. So I thought that was really well laid out in the article.
Thank you. And I'll tell you that there's not universal agreement about the active titration or active management of, outpatient, quote unquote, chronic conditions like hypertension in the hospital setting. And I totally understand that. At the same time, where I work at a VA, I have access to outpatient blood pressures, and I can see if someone is always 160, 170, 180 and feel a little bit more confident, doubling their dose of amlodipine. And feeling as though I'm not going to, cause them to plummet when they get home.
Although I do feel you don't necessarily have to have an EMR to support you. Some patients are able to give you just pretty good history and say, oh yeah, I'm always like in the 180s over 100s or 200s. So what I'd like taking away from this is just looking at like, they're just hypertensive. Treat them like they have hypertension like you would in the outpatient setting. Right. Look at reasons for resistant hypertension, titrate their oral medications because that'll probably give them better benefit in the long run. I think I read a similar update on like hypertensive emergencies that Paul Merrick wrote several years ago. You didn't reference his article in your citations, but I thought one of the an interesting thing he was telling about hydralazine, which I had never known, was that apparently hydralazine after administration has a latent period of 5 to 15 minutes, followed by a progressive and often precipitous fall in blood pressure that can last up to 12 hours. Although hydralazine's circulating half-life is only 3 hours, the half-time of its effect on blood pressure is about 10 hours. So I was like, wow. And of our medications that we use for hypertensive urgency is like hydralazine and labetalol. So I was just,
oh, wow.
I'm like, well, if that's a horrible medicine to use anyways, then am I doing any good by using these medicines at all?
Yeah, and one of the studies we talk about in the review is a randomized trial where they looked at telmisartan, and I think it's an ACE inhibitor, versus rest. They actually randomized patients to get one of those two. And at 2 hours, there was no difference in blood pressure. But at 30 minutes, rest was better. And by better, I mean it lowered the blood pressure more. So patients' blood pressures fluctuate. And if you just reassure the nurse and give them some time, their blood pressure oftentimes will come down.
Right. And you have to think about what are you really accomplishing? Like it's in the same way that no one gets an acute diabetic foot. Like it's the same thing. If someone's, hypertensive crisis is one thing, but if someone just has an elevated blood pressure, what are you really fixing by making that number look better other than maybe a few more hours sleep of night float? Like you're not saving lives or prolonging anything at all. So it's just a big picture. What are you trying to accomplish?
It sounds, Paul, as though you're trying to argue that deciding scale insulin is something you do for no reason.
I might suggest that as well. Yeah. Someone should write something about that.
I think another takeaway that I've sort of extrapolated from all this discussion about hypertensive urgency is the fact that, in the outpatient settings where a lot of our listeners come from, they'll have patients who walk in with a blood pressure of like 210 over 120, and should they freak out or should they not? And, if even in the inpatient setting, we're just like making sure they're asymptomatic, there's no other evidence for end organ damage, and we just titrate their oral medications, maybe that's something that we should be able to do in the outpatient setting and not have to freak out and send people into the ER where the ER docs are just going to shrug their shoulders and be like, I don't see any end organ damage. Go back to your primary care doctor.
Yeah. And one of the other studies that we referenced looked at 58,000 patients who presented to outpatient clinics with hypertensive urgency, and just 100 out of 58,000 were admitted to the hospital. And when I present this data to hospitalists and I say, hey, 58,000 patients seen in outpatient clinics, what percent do you think were hospitalized? They're like, 20%, 30%. And I'm like, no, guys, 0.1%. Outpatient providers deal with this all the time. They do not admit these patients.
Yeah, and there's another study that looked at this. And the patients that are sent to the ER at 6 months, the only thing that's different with asymptomatic hypertension, whether it's treated in the office or whether you send them to the emergency department, is if they're sent to the emergency department, they're more likely to be admitted to the hospital. At 6 months, their mortality is not any better. Their blood pressure is not any better. Like nothing else is different. They just had some time in the hospital after you sent them to the ER. So just manage it yourself if they're asymptomatic and they're not an emergency.
That seems like a fantastic point to end on. So we're going to give this 10 hotcakes, right? So that's like a super stack.
Well, I thought we poached the 4 hotcakes from Matt's study because I don't think he gave any hotcakes.
Yeah, I did not give hotcakes. Chris didn't give you the opportunity, but well, let's throw them over to your to this study.
I'll use it when I'm up for promotion. I'll tell patient. I'll tell them, hey, guys, look, 10 hotcakes for this one.
Well, that's the end of all our articles. I mean, Tony, do you want to give us any wrap-up points from this great discussion we've been having with you?
So I'd say exercise and you'll be more healthy. Take aspirin if you're having an acute MI, unless you're Gemini or Libra. If you have severe diastolic hypertension, get that under control, and wait for, I guess, did you say, Matt, is the ACC meeting next month where they're going to be presenting the data? AHA. So hold out another month before we figure out whether or not you should be taking EPA.
Yeah, actually, by the time this comes out, it'll probably have been that will already be out there in the world. I think. We'll see.
Excellent.
Not to be confused with the Environmental Protection Agency.
Which will not exist by the time this is out.
Election day tomorrow. Everyone vote.
Thank you for listening to another episode
you're welcome,
Curbsiders. Oh, hey. Episode of the Curbsiders Hotcakes and Hot Takes. Please see our show notes for the references to all the articles discussed. If you want to know what else is on our reading list, you can email or tweet at us for that info. We want to thank you all and our listeners, like Dr. Tran Pham over at the LSU Lake Charles Family Medicine residence, for all their feedback and support of the Curbsiders and the evolving series.
That's right. This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. You can find show notes along with links to any articles, books, websites, or apps mentioned on the show at thecurbsiders.com/podcast. You can also sign up to receive our weekly mailing list at thecurbsiders.com/knowledge food.
We are committed to providing you with high-value, practice-changing knowledge, and to do that, we need your input. So please subscribe, rate, and review the show on iTunes, or send us an email to thecurbsiders@gmail.com. You can recommend a future topic or tell us what you love or hate about the show. And finally, you can follow us on Facebook, Instagram, and Twitter at The Curbsiders. I'd also like to put out a special thanks to our team of correspondents who help keep the show running, including Hannah R. Abrams, who runs our Twitter account, Beth Garbatelli on Instagram, and Chris Chiu on Facebook. Also, a special, huge, extra large, super duper 10-stack hotcake thanks to Sarah Roberts, who helped produce this episode and did a lot of heroic preparation, as well as Chris Chiu, who also did yeoman's work in helping to coordinate this episode.
It's very loquacious of you.
So until next time, I've been Dr. Matthew Frank Watto.
I'm Christopher Chiu.
And I'm Dr. Stuart Kent Brigham. And good night. Good night.
And I remain Dr. Paul Nelson Williams, and goodbye.
Oh, hi, Paul.
Tony was trying to apply a future hotcake rating scale to the current hotcake, and unfortunately that's not permitted by law of physics. So I just felt like it was important to emphasize that we are in a rule-bearing situation here.